Good morning, everyone. We're going to get started. For those of you who don't know me, I'm Margaret Steele, and I'm proud to be the Dean of the Faculty of Medicine here at Memorial University. Now, this session is being recorded, just so that you're aware, and that if you have questions, they'll be on the recording. I'm delighted because we also have people from Happy Valley, Goose Bay, and other parts across the province, so we're delighted. So it is my absolute pleasure to introduce our esteemed alumni, Dr. Deco Mandavia. And Deco is actually from Grand Falls, Windsor. So some of you may know him from that part of his life. So I'd like to begin by respectfully acknowledging the territory in which we gather as the ancestral homelands of the Beothuk and the island of Newfoundland as the Mi'kmaq and Beothuk. I would also like to recognize the Inuit of Nitassinan, or Nunatsiavut and Nunatuvet and the Innu of Nitassinan and their ancestors as the original people of Labrador. We strive for respectful relationships with all the peoples of this province as we search for collective healing and true reconciliation and honor this beautiful land together. So just a little bit about Dr. Mandavia. I know some of you may have spent some time with him yesterday. Dr. Mandavia started his medical career here at Memorial, and he's a proud graduate of the MD class of '89. And since then, he's had a very exciting and interesting and accomplished career. Dr. Mandavia is an expert in point-of-care ultrasound and how this technology can improve care while decreasing costs for health systems. As Chief Medical Officer of both Fujifilm Sonosite and Fujifilm Medical USA, he has served as a consultant for multiple health systems within the USA and abroad, and has helped develop programs that have improved quality of care, decreased cost, improved patient safety, care pathway efficiency, and patient satisfaction. Dr. Mandavia is also a clinical associate professor of emergency medicine at the University of Southern California, and was an attending staff physician at Sinai Medical Center in Los Angeles from 1998 to 2010. Dr. Mandavia is a member and past chair of the American College of Emergency Physicians, otherwise known as ACEP, the ultrasound section, and co-author of the ACEP ultrasound guidelines. He's taught thousands of physicians worldwide, lectured at over 200 medical conferences, and has been awarded ACEP's Outstanding Speaker of the Year. Dr. Mandavia has also contributed to over 90 publications and is co-director of the National Resuscitation Conference, as well as a business graduate of the Stanford Executive Program. He's also the executive producer of the award-winning film Code Black. And I'd love to know what you do in your spare time, Deku. It's my pleasure to invite Dr. Mandavia to share his knowledge and expertise. And following the presentation, you'll have an opportunity for questions. So welcome, Dr. Mandavia.
Wow, thank you, Dr. Steele. It's an absolute honor to be here. As Margaret has stated, I've had the opportunity to speak literally around the world, but I get even more pleasure to coming back home. And, I had a great tour yesterday through the medical school, and as much as I was delighted about this new addition, I was especially interested in seeing where I was taught some 30 years ago. I will tell you that the training here that I received was phenomenal. Served as the foundation for me to do a lot of great things. So I tell you that in sincerity. I remember distinctly as I entered the United States to do my training, and I could see a difference of my sort of clinical skills versus my colleagues. And I think that's the intimacy that you get something special here at Memorial, something that may not be immediately recognized. So I'll tell you that the product that you're creating here, Dr. Steele, is a great product. The students are certainly well trained to do some phenomenal work. Well, I'm here to share with you a passion of mine, and that's point-of-care ultrasound. And it's been in a very important part of my career. I'll take you through that. I am not a radiologist. Again, I take care of emergency patients, trauma patients. That's my specialty. But my entry into ultrasound was an unusual one. This is a picture I took yesterday. Um, and if you want to look for me, I'm on the fourth row and fourth one in from the left. And in the 1980s, I had a mustache. I looked quite different, but it was great to see all of those photographs and again the location of where I learned medicine. So once I finished medical school, obviously I had to do postgraduate training. I was fortunate to do internship in Ottawa, but I got exposed to emergency medicine and emergency care through different experiences, both here at Memorial and in Ottawa and even on rotations. And I realized that I really had to do a true residency training program. And at that time, you could actually work in emergency medicine without a residency training program. And in fact, I did. I worked in Southern Ontario for after internship. But it was also always my goal to do residency. And to me, I knew I had to go somewhere where there was a lot of action, a lot of emergencies, a lot of trauma. And I was fortunate to match at LA County USC Medical Center. At that time, the largest program in emergency medicine, the first program ever established in the world. At that time, we had over 72 residents in emergency medicine, a 4-year training program. So I arrived there in 1991, and I thought I was coming to a hospital. I had been at the Ottawa Civic. I knew what really nice hospitals were like. In fact, I would describe I arrived at a MASH unit. I arrived in the early 1990s in Los Angeles, where unfortunately there was a lot of violence, a lot of gang-related violence. The hospital itself was located in not a great area. It was located in East Los Angeles. So a tremendous number of knife injuries and gunshot wounds, things that I'd never been exposed to. And it was a very unusual experience. And it was in a structure, a building that was built in 1933. It was a great place to do my training, but at times it was also very frustrating. We were overwhelmed with the patient volume, and I was unfortunately seeing patients that were dying needlessly in front of me with undetected internal bleeding, undetected pericardial tamponade from a stab wound, because the tools that we had at that time were very limited. We did have a CT scanner. It was on the 3rd floor and 3 football fields away. So it was easily a 1-hour round trip. That was a single detector scanner. So with that volume, there was no way. And then one day I got introduced to ultrasound, and ultrasound at that time obviously was available. The imaging was not as good as it is today, but they were available. They were quite large. Practically speaking, could not really fit into a trauma bay, even if an individual was trained. And then somebody introduced me one day to a miniature ultrasound. This miniature ultrasound was the size of a small fridge. It weighed about 300 pounds, and there it is, that's that device there. And I was absolutely fascinated that you could take this transducer and you could look below the skin, and you could see the organs, and you could see internal bleeding. And to me, it was a wow. My eyes were wide open. Think of this, I was a young emergency medicine resident at the time, and this was not in the curriculum. This was nowhere on the radar screen. And it was pretty radical for me as an emergency physician to be pushing around an ultrasound in the emergency department. A lot of people thought I was crazy, including some of my peers. But what I recognized that it had something, what we call today space validity. It made sense. It made sense that if we could get that answer quicker, faster, the patients would survive. And that's exactly what happened. So obviously, we're all familiar with imaging. Imaging plays a huge role in medicine today. Most of that imaging is traditional imaging, right? So what happens is a physician orders a test. That test is then, the patient then goes somewhere to get that test, right? Whether it could be a clinic or an office, or sorry, a hospital. The test is performed, whether it's a CT, MRI, or ultrasound. Some technician is often involved. Then that's acquired, sent to a PAC system. Sometime later, a radiologist will read that imaging test. A report will be generated on that. Once that report is generated, the report is then sent back to that referring physician. A period of time happens. It gets to the referring physician. Eventually, the patient's contacted with that test result. Then the patient said, please come into the office. What is happening is a very long period of time from the time of the initial physician to want a test to some form of an answer or the next decision point. And that's really the difference in point of care. Point of care is immediate. It's immediate and it's actionable. And it takes a lot of those steps that add to delays out of that. And particularly in time-sensitive situations, that delay is intolerable. In my initial exposure to point-of-care ultrasound, was now what we call point-of-care, it was the emergency patient. It was the critically ill trauma patient. It was the patient with internal bleeding that could not wait. The other thing, obviously, those that practice medicine understand there's two standards of care. There's a standard of care that happens between 9 and 5, and there's another standard of care after 5 p.m. And, you know, I struggled with that as a physician. And how could we normalize that care? How come patients that arrived after 5 o'clock, why could they not get that test? Especially when that test was really important to their care. And point-of-care ultrasound helped get those patients those sort of imaging. So remember, so in point-of-care, it's not really as much about the image. Image is important, of course, yes. It's more about the answer. You know, what am I doing with this patient now? What's the next step with this patient? So they're complementary tests. It's very important to understand this basic concept. So the question is why? And you know, what I'll tell you, there's real compelling reasons to integrate point-of-care ultrasound. You know, there's an investment of time and energy and training, of course, but the benefits are priceless. So clearly, what should drive all of us is to improve patient care. That's how I got involved with ultrasound. There was no other reason. If that service was available, immediate, I wouldn't be here today talking about point-of-care ultrasound. So almost I probably wouldn't have been a company. But these were disruptions that were occurring, and the ability to normalize and provide that same sort of standard, not even 24 hours a day, perhaps in a different location. You know, in a province like this, we have patients that are throughout the province. How do we get better access to care? Quicker diagnosis often means earlier treatment. In many conditions, as we know, an earlier treatment is preferred. We have a lot of efficiency with point-of-care ultrasound. We have a large hospital here. Why would you take a patient from the ICU and bring them down to radiology for a DVT study? When that patient's on a ventilator, multiple drips, it makes sense to do the test at the bedside. Patient safety drives a lot of what we do in hospitals today. I'll talk a little bit about that. Risk management, I think it's, in today's world, you want to have your clinicians more empowered, more data, more confidence in their decision making. Point-of-care ultrasound does that and helps decrease your litigation. Cost reduction is a great benefit where we can mitigate to some degree CT utilization or MRI utilization or even perhaps patients transfer. That's really important. And again, the people that benefit are the patients. And we know firsthand that patients like this. In fact, there's been studies showing that when physicians are involved with point-of-care ultrasound with their patient, the patient's perception of the care is better. They feel that there's more engagement, and of course, there's a lot more emphasis on how the patient feels about their care today. So let's take you through some applications. So again, my entry in was by necessity. The FAST exam didn't exist when I started doing ultrasound. We recognized that we could take this technology and find internal bleeding, and there were centers around the country that were doing similar work. Eventually, the FAST exam was coined. And so this is a case that I looked after that's consistent with a case that would happen here. So you have a patient who's 25 years old who's been run over by a car. His blood pressure is 80. He's got a pelvic binder on because he's got an open pelvic fracture. Now, all of you know that's a life-threatening injury. They can bleed to death in front of you. It's a talk and die scenario. The bleeding can be retroperitoneal or it could be peritoneal. So the next decision is, where should this patient go? Should this patient go to CT? Should this patient go to angio? Which teams do I need to call? Guess what? Ultrasound can help answer those questions. So we can take this simple transducer And I know some of you are experts and some of you may be just learning ultrasound, so sort of giving you a broad brush here. Taking this small transducer, which is similar to a flashlight looking inside the body. And we can see on the right-hand side the image that you'll generate, and guess what? That black stripe you see there, that's blood. And multiple studies have shown that you can train physicians to find this focus finding. Again, this is not training physicians to do comprehensive ultrasound to learn everything about that entire region. But is this patient having internal bleeding? Yes or no? And guess what? The FAST exam is very beneficial. Many patients obviously can succumb to a pneumothorax. And sure, you can get a chest x-ray, that takes time. Breath sounds can be hard to hear in a noisy emergency department, or even inaudible if you're on a helicopter, say. Guess what? You can actually look at pleural surfaces. So if you can see the pleural surfaces move, and this is the lung sliding side, that rules out pneumothorax. So this has become part of our standard way that we assess trauma patients. So, whether it's a trauma patient or whether we just place a central line, we will quickly look with that transducer and look at that lung sliding. We will be confident that a pneumothorax has been ruled out. In fact, this approach is CT accuracy. Lots of reasons to do ultrasound for the abdomen, and this is just a handful. And what I'm particularly delighted about is, as I read the literature, there's more and more applications. I see it a lot of young physicians and probably residents here in this room. These physicians will discover new applications. But let me take you through some that are well recognized. Certainly in Los Angeles, we have a big Hispanic population that suffer a lot of biliary disease. So it's very common for us to see biliary colic, cholecystitis. And so how do we augment what we do from our physical exam? We can quickly look now. We can see, do they have stone, yes or no? Do they have sonographic Murphy sign? Do they have pericholecystic fluid? All of this is very helpful information. Certainly one of the biggest emergencies, time sensitive in the abdomen, is an aortic aneurysm. These are very satisfying cases if you can get them quickly and get them to the operating room. And even in a large city, this sort of operation is not usually performed 24 hours a day. That means we have to call people in. And if you look at a province like this, if someone even has to come from Whitburn, as an example, which is still not that far away, you would still need to call your vascular team here and ready. How can we accelerate that? If there's a suspicion from the initial provider, can they take a transducer and quickly see? That data will help us mobilize the team and hopefully improve patient outcome. Similarly, but on the other spectrum, that can also cause flank pain, are kidney stones. And though nobody dies of kidney stones itself, of course, very painful, excruciatingly painful. Question is, especially in young adult, can we mitigate the use of CT in a low-risk population? Can we instead do bedside ultrasound? Can we compare one kidney to another? Can we detect hydronephrosis? The answer is a resounding yes. So it's a great opportunity to mitigate the use of CT and improve patient care, decrease cost. Of course, we're also cognizant today of the CT risk. CT is a great modality. We use a lot of CT. We use a lot of MRI as well, but there are some risks, right? As physicians, we need to understand this. And remember, this is a lifetime cumulative dose of CT. So we need to be cognizant, especially in the child, in the young adult, of how much CT they're getting. So now, for the first time, we're now considering ultrasound first pathways. Could that give you the answer, get you enough information, and use CT in a more high-risk case or in selected cases? To me, that makes a lot of sense. Here's an interesting one. So when you take this technology, point-of-care ultrasound, you take it out of, say, radiology, and you give it to a clinician, guess what? What happened when you gave it to emergency medicine? Well, people come to the emergency department with vision loss. And all of us have been trained to use an ophthalmoscope, but I'll tell you, I can't see the retina that well with a thumoscope. In fact, most physicians can't. Guess what? We could train all of you in this room to see the retina. And what's beauty of this is it's immediately there. So now in my emergency department, and now this is now a standard of application in emergency medicine, take that simple transducer, put it on the eye, and you can actually see a retinal detachment. And of course, that's incredibly important to detect quickly. So this is an example of a super application that's now made itself into mainstream medicine. Echocardiography, in fact, one of my earliest applications that I started doing was echocardiography. So remember, in the early 1990s, we had a lot of penetrating heart injuries. So a lot of stab wounds to chest, a lot of gunshot wounds. And at that time, there was no real way to detect a pericardial effusion at the bedside. There is no other way. We were doing, obviously, a chest x-ray, EKG. We were doing CVP measurements, believe it or not. None of this was sensitive or specific. Why would you not take a transducer and actually look at the heart? Look at the organ in question and see, is there fluid surrounding that heart? Yes or no? How well is that heart beating? How's that contractility? You know, we see tremendous patients with shock, peri-arrest, or even cardiac arrest. And echocardiography is incredibly important. Just this past week, I met with about half a dozen experts in transesophageal echo. They weren't cardiologists. They're ER doctors and ICU doctors that were doing transesophageal echo to improve cardiac arrest outcomes. And I learned a lot from them that, in fact, one of the most important things, obviously, is good, effective CPR. We have no way of knowing what effective CPR is. Well, what if you could look at the heart and see if indeed CPR is effective? So this is ultrasound-guided cardiac resuscitation. So this is my hospital in Los Angeles. We have 12 trauma bays. And obviously, when you do resuscitation, a monitor is important, defibrillator is important, all the other components around this. Guess what? We believe ultrasound is important. In fact, every resuscitation bay has an ultrasound device. It's that critical. And this was installed in 2008, so 10 years ago. It's that critical a technology that we use it so often. And these are the sort of trends that are happening to use point-of-care ultrasound. Lots of other reasons. I mean, I could talk probably all week of all the different conditions that point-of-care ultrasound can play a role, but let's take you through a handful. This is a case that I looked after. This is a 40-year-old construction worker who presented pain in his left palm. He says there's a large piece of wood, like splinter, in his palm. We consulted, we got an x-ray, as normal, as expected. We couldn't see anything because it was wood. We're pretty confident it was wood there. When a patient tells you there's a foreign body, almost always is a foreign body. And so orthopedics looked at it and said, no, we don't really think there's anything there because the x-ray is normal. I said, no, back off, hang on one second, bring the ultrasound. So we brought the ultrasound in. And can any of you see anything a little bit unusual in that image that does not look like a normal part of anatomy? Well, I hope you see there is a linear hyperechoic line here. That was a large piece of wood. So 2 hours later, this guy was in the operating room, and his head was removed from the palm of his hand. These are the examples of real life stories, and these occur now, fortunately, daily across the country and literally around the world. So lots of reasons to do ultrasound for procedures. That was another eye-opening area that, hey, that when you're putting a needle deep into the body, why would you not look where that needle is going? Right? Especially some of these are followed by catheters that can be quite long and deep and invasive into the heart. And so ultrasound allows that safety guidance. And we know that medical errors are a big cause of morbidity and mortality. That's well recognized. That's why we do a lot of things the way we do in a hospital nowadays. Why we have checklists and so care pathways. And I can talk a whole lot just on this area. But let me take you through some cases. Obviously, you know, I came all the way from Los Angeles, so I feel compelled to share something from Hollywood. And I worked with the writers at NBC when the show ER was on. So let's take you through a case which I think depicts a case that might be real and seen.
That's the law. We need to slow down his rates. Can I Oh, you got sugar in here? Oh, wow, we got a trauma. I don't know. Page is probably not working. No, my page is working. 20-foot complicated by unknown intoxication. What are you guys doing? A femoral cut down. Whoa. Everybody take a deep breath. Take a deep breath. Get my briefcase under the acne. Banana cheese. Yeah, banana cheese. What do you think? That's it. Attacking the dry. This one, yes, it's about rest of the gas. 2 weeks of IM. He's still laying back James! What do you have to play for? What time did the country out come back? We got weird anatomy. We couldn't find a subclavian. There it is, there it is. See, the probe allows us to cannulate the vein visualization.
That's very cool.
You carry that around with you all the time? It's just a demo. I ran the phase 3 trials. It's like shooting fish in a barrel. Heart rate's down to 80. Guess we didn't need the beta blockers, did we? I trust you guys can finish it up.
So it's like shooting fish in a barrel. You know, it's funny when you start using ultrasound, it's almost like cheating. I'm sure there's lots of experienced physicians here that have placed a central line without ultrasound, and I placed a large number without ultrasound. Would I place another one today without ultrasound? Never. Why would you, when you can quickly see the anatomy? We already know in 1/3 of the cases that the jugular vein, which is the target, is not where you thought it was supposed to be. So those surface landmarks aren't accurate. We know that. And those that have placed enough lines have seen enough complications, and those complications can be pretty severe. Well, what does the literature show? Well, the literature shows that, yeah, guess what? That visualization decreases complications. And if there's any residents here that want to do research, don't do any ultrasound research for central lines. Why? The stack of papers is this high. We don't need any more research. The research is best described as overwhelming. Overwhelming. The AHRQ, Agency for Healthcare Research and Quality in the United States, has made this a best practice. In the UK, the NHS has made this best practice. Guess what? Unfortunately, you're still going to find many hospitals still aren't using ultrasound. And again, a simple intervention that can decrease complications, especially we're all now in a world where there's not enough healthcare dollar. Doesn't matter where you are, right? And we have a larger population, an aging population, a sicker population. How do we provide that effective care? And what would you want for you or your family? To me, the answer is obvious. Here's another procedure, paracentesis. So, you know, we've actually outlined this gentleman who has cirrhosis, his liver and his spleen that you can see on the left side, and that's his ultrasound. And, you know, you can do shifting dullness and things like this, but you don't really know where the needle should go. I mean, we already know that if these patients are coagulopathic, the thrombocytopenia, they bleed a lot when you hit the wrong organ. So if you can guide that needle safely, ensure you're in acidic fluid, not even potentially in the bladder, the evidence is clear. Use ultrasound. Same thing with thoracentesis. Very complicated, especially when you have small amounts of fluid. And if you need diagnostic thoracentesis, not even a therapeutic thoracentesis. So you can, again, with that simple transducer, you can see the diaphragm. Anacorc areas represent fluid. I'm not even talking about chest ultrasound. That's another whole lecture, how we can detect B lines and detect pulmonary edema, detect pneumonia. Point of care ultrasound is a game changer there, but this is just for procedure guidance. So we can drop the iatrogenic rate for pneumothorax from 18% to less than 3%. And with skilled providers, it probably approaches 0. And so this is where we all should be. How about neuroblocks? It's interesting. Within sonosite, anesthesia is actually our most adopted point of care user. And it was actually regional anesthesia and vascular access that drove that. So obviously anesthesiologists, they provide anesthesia. And the question is, could you block a region? Could you do regional anesthesia? Could you do that effectively? Well, why not empower an anesthesiologist to look and see the target nerve? Place the needle closely to that, place your local anesthetic. Guess what happens? Patients have a better outcome. They have less pain, they have less recovery time, less opiate usage, which we know is a problem. All of these things lead to less cost, right? We're an aging population, therefore a higher risk population. Regional anesthesia makes a lot of sense. So how do we facilitate more regional anesthesia? Ultrasound guided nerve blocks can help a lot. So here's an example where you can see the nerve that's outlined. You can see the artery. Remember, they travel together. Neurovascular bundle travels together like this. So you want to avoid the artery and the vein, but you want to make sure that the anesthetic is placed appropriately to get a good nerve block. Again, a very, very important application for point of care ultrasound. So point of care ultrasound, is everywhere. This is a friend of mine, Dr. Yannick Ballou in Montreal, a very big proponent of point of care ultrasound. He's in the ICU, he's using it for everything. Whole body ultrasound is a term that's now used. Here's an anesthesiologist in Mumbai. I've been fortunate now to literally travel around the world and enter hospitals, enter operating rooms, ERs, and guess what? There's a role for point of care ultrasound everywhere. A lot of role in developing world. I know there's a group of physicians that do global health work here at Memorial. To me, the Venn diagram of global health and point of care ultrasound is nearly an overlap. A lot of my colleagues that are doing global health are very skilled in point of care ultrasound. It has a big role there. This is Thailand. This is a surgeon who's actually confirming the presence of appendicitis prior to the operation. Again, point of care ultrasound is not a single specialty. It's all of medicine, and it can improve patient care. Do you think this surgeon has access to a CT scanner there? Probably not. This is at that location, probably a physical exam diagnosis. You might get a lab test. That's about it. Ultrasound here, game changer. This is the Haiti earthquake. This is a team out of Stanford. When the Haiti earthquake hit, we actually, in the ensuing 10 days, sent about 200 sonosite units there. Why? The people that respond to natural disasters include emergency medicine, critical care, anesthesia, surgery. Those are the specialties there. And they're the specialties we work with a lot. And interestingly enough, the #1 operation that was done in Haiti was an amputation. And guess what? How that was an amputation was done under regional anesthesia. And so when you don't have an operating room, when you don't have general anesthesia, how can you provide humane treatment? These are some of the technologies. These are the technologies that these physicians that deploy quickly take with them. And so there's a lot of evidence now. And I actually don't have time to review that. There are lots of good sources for the evidence. But this is a particularly good landmark article from 2011. This is a New England Journal of Medicine describing point of care ultrasound. And you get a better understanding. Wow, this is a disruptive technology that's hitting medicine like a tsunami. That's what's happening today. And here's a good idea. The evidence that's mounting, and it continues to grow. Why is this rate going higher and higher? Because we have more and more specialties. And these specialties are discovering even newer applications. Applications that would not have been considered or not have known until it got into the hands of that specialty, and then they realized it could solve the problem. This is all about trying to solve a problem. To me, point-of-care ultrasound is a lot like a Swiss Army knife. All of us could carry that. We might use different parts of it in different ways, but we won't leave and go camping without it, or won't go to a hospital without it. And this is point-of-care ultrasound. The guidelines are also reflective of that. If there's any debate or calls or what's the evidence, these are evidence-based guidelines from around the world, from nearly every medical specialty, that are, again, serve as great blueprints for those that want to integrate ultrasound. And so this is delightful. I was very proud to be part of the ACEP organization, founding member. We wrote the first guideline because it was required, it was requisite, and sort of paved the road and broke some barriers. And now we have lots of guidelines that are really helpful to individuals trying to integrate point-of-care ultrasound. Lots of societies, lots and lots of societies. And we know that physicians, especially within their specialty, typically look to their society for guidance, right? It's usually not as much a licensing board, but more their society. What does their peer group in the society say? Guess what? Those peer groups all say yes. They all say yes all around the world. And we are seeing, again, from my vantage point, from a global standpoint, more and more societies just coming on board. Why? Their society members actually want that training. They're wanting that training. They're realizing that, in fact, it's going to ultimately improve patient care. This is a positive thing to do. And so at Sonosite, I'm in charge of our educational programs. I'm proud to say we do more ultrasound education than all the other companies put together, period. And that's what we do, because that's what point-of-care ultrasound requires. Education is extremely important. We work closely with all the societies. It's interesting to see the growth of point-of-care. We've been talking thus far really about physicians. Guess what? There's a lot of other people that provide care. In the pre-hospital phase, obviously, we have sophisticated paramedics. There's a role for ultrasound for paramedics, whether it's air flight, whether it's ground ambulances, or whether it's even different environments. As we know in Europe, especially in France and Germany, physicians provide care in the field, including very, very sophisticated resuscitative techniques, including ECMO in the field. So point-of-care ultrasound in that sort of environment, absolutely. But there's lots of other reasons. Like, for example, we just talked about pneumothorax. Well, how well can you hear breath sounds in a helicopter? Have you been in a helicopter with a stethoscope? Right. Remember that stethoscope that we still put in our white coat? That's 200 years old, by the way. 200 years old. It's more today symbolic than a real diagnostic value. And there's lots of evidence to show this point-of-care ultrasound can really empower the clinician. So in this case, we're talking about the pre-hospital phase. Nurses. So as Dr. Steele said, I spent a lot of time at Cedars-Sinai Medical Center in Los Angeles. And in an effort to improve patient care and to avoid central lines, I would often put an ultrasound-guided peripheral IV. Right? So it was a little deeper, a little longer catheter, but in the antecubital area usually. And I do that a lot. And eventually the nurses would always be calling me, hey, Dr. Mandavi, do you mind just putting an ultrasound-guided peripheral IV because we had trouble? Hey, Dr. Mandavi, do you mind putting an ultrasound-guided peripheral IV because I have trouble? I said, okay, knock it off, knock it off. I'm just going to train you guys and then you guys place them. So we did that. And so I trained the nurse educator there at Cedars, and they started a program, and they started tracking everything. They presented their work at Emergency Nurses Association, and they won the national award. This was probably 7 or 8 years ago at least. What we're seeing is a tremendous uptake of nurses doing ultrasound. So nurses typically are the first line providers to do peripheral IVs. We just mentioned we have aging population, we have recalcitrant patients, we have obesity, we have many reasons to have difficulty getting an IV. Why would you not empower the nurse with visualization? That's happening today. If you want to see some great video stories, go to sonosight.com, go to the evidence page, and you'll see some of these stories, including a great video-based story of how St. Joseph's Hospital in New Jersey was able to integrate a nurse-based program and achieve a lot of cost savings because they were able to avoid the central line because a portion of these patients were just getting a central line just for access. It's kind of crazy. And so there's another story there from Thomas Jefferson University that they were able to eliminate 75% of central lines. So in medicine, as you know, there's two numbers you want, 0 or 100. That's the numbers, right? And so if I said to you, how do you get to 0% pneumothorax? Guaranteed, I would say don't do the central line. So do a peripheral IV. How would you get guaranteed 0% central line associated bloodstream infection? Guess what? Don't do the central line. You get zero eclampsia. So an ultrasound guided peripheral IV gets you 0 and 0. And in many patients, it makes a lot of sense. And now with increasing use of the midline catheter, this is all going to start taking off. To me, it makes a lot of natural sense. We're seeing a lot more evidence of use of point-of-care ultrasound in a primary care setting and internal medicine. This is an article from Mayo Clinic Proceedings, a really good article. In fact, Dr. Bagra breaks it down, actually describing the differences of what the classic conventional ways of assessing versus using point-of-care ultrasound, and makes a very compelling, sort of coherent argument why point-of-care ultrasound should be integrated. And so we're seeing a lot of this. I think this has a lot of relevance here in Newfoundland particularly. And you know what drove me here, and one of the projects which I'm really excited to be about, and when I met with Dr. Steele in Seattle, was that Memorial is going to take a bold step and actually go to integrate point-of-care ultrasound into the undergraduate medical school curriculum. To me, this is very exciting. Memorial is charged with training doctors for tomorrow. Tomorrow's medicine 100% will have point-of-care ultrasound integrated. So to me, starting at the medical school level, having these young students learn literally on day one as they learn all the other clinical skills is the right way. Point-of-care ultrasound is a lot like learning a language. You know, the earlier you learn it, the easier it is. I see it, I witness this every day. I see students doing ultrasound, I see residents doing ultrasound. They're just wired differently. They just immediately take to it. They're fascinated by it, and they're self-learners. Fortunately, there's lots of good resources online and other locations that, guess what? They will adopt and learn, and they will be whiz kids. Now, it will be a little disruptive to full professors and others that have been working for quite a while. It's a good disruption, right? It's good when when the medical student is detecting pulmonary edema with a beeline on ultrasound, and the faculty are typically used to looking at an X-ray. That's disruptive, but it's a good disruption. It's the right direction. Secular change is happening here, and so I'm very excited that Memorial is taking this bold step because I think it's going to have a lot of value. Also, we're seeing a lot of teleultrasound, whether it's remote reading or real-time reading, and there's opportunities, particularly in rural populations or populations that are more remote. Ultrasound is actually a technology that is conducive to this remote review. There may be a concentration of experts here in St. John's, but that concentration doesn't exist the rest of the island. How do you normalize? So that was one of the things I wanted to do when I first entered ultrasound. So there's truly a global disruption happening. These are some of the medical specialties that are using ultrasound. There's a lot more that are coming on board. I'll tell you, it's exciting. You know, back in 1991, when I was using ultrasound, I had no idea. You know, I was solving the problem that was right in front of me. I had no idea that the technology would actually be disruptive in medicine and healthcare as in a general sense. And the reason this will continue to drive forward is some of the things that are happening around us, the environment. As I mentioned, health systems are running out of money. They have a lot more population, aging population, disease burden is higher. Expectations are also higher by the population. So I've shown you with some illustrated cases, you can improve quality of care, right? With point-of-care ultrasound, you can have efficiency. You can bring the device to where the care is happening. You can get that answer immediately. You can decrease time. I'm sure there's a lot of, say, backlog for imaging for many patients. How do you decrease that? We can improve patient safety. Some of these have already been recognized as standards of care, absolute standards of care. So empowering clinicians to do this. Patient satisfaction. I guarantee you, patients will love it. Again, even just the perception, you know, often as physicians, we're criticized, but not spending enough time with the patient, right? And it's hard because you have a lot of patients to take care of. But just that act of doing an ultrasound by default, many technologies, let's say, how about tell you, many technologies separate doctors and patients. You know, a good example would be electronic health record. You know, separates them. But point-of-care ultrasound actually connects you more with the patient. It's a technology that helps develop that bond. And lastly, huge cost reductions. Depending whether you're looking on the diagnostic side, on the ultrasound guided side, it just makes natural sense. So in summary, I hope I've shown that indeed point-of-care ultrasound is a disruptive technology. It's low cost, but high value. It has a lot of benefit in the triple aim. And it's an adoption that's happening rapidly. And it's a really exciting movement. And I'm particularly excited to make the trip here to St. John's, to Memorial University, to my alma mater, and to see some great work happening here. So thank you. So I think we're going to take some questions now, right?
Hi, can you hear me down there?
Yes.
Thank you very much for the talk. It's very enlightening. I'm a medical student here. My name is Michael. I had a question regarding education. So we know that ultrasound is very critical in this day and age. And so regarding the education, teaching learners, I saw a lot of patients, or I guess learning on each other, but for like procedures, like training CIDs or placing central lines or whatever else. I'm wondering, like, how much use of simulation do you have currently? So maybe if you could talk to some procedures that are well established, and also follow up to that, what other applications, procedure-based, that you haven't seen simulations being developed to help with that? So are there some procedures that you say, you know, these are really great applications of ultrasound, but how can we better support this?
Okay, so I'll repeat because I know we have some people online. So the question is largely focused on ultrasound simulation around procedure guidance. So the good news is there's a lot of good simulators that are out there. Certainly for vascular access, and I'll tell you, you could literally take a chicken from Sobeys and put a Penrose drain in, and that's a pretty good simulator. But with that said, there are professional simulators that you can use for vascular access, thoracentesis, paracentesis, even nerve blocks. Um, and the simulators are getting better and better. There's good diagnostic simulators as well. That's a separate sort of conversation. I will tell you, nothing beats true scanning on humans. Of course, on the procedure side, we want lots of practice. One of the things that is important is the hand-eye coordination, where your transducer is and where your needle is. That should obviously be practiced in simulation. And I was delighted to see that, in fact, you do have some of the simulators in the sim center here.
Thank you.
Yeah, welcome.
Other questions?
Hi, my name is Julie Luz. I'm the Regional Director of Diagnostic Imaging. First, I'll say I'm a big proponent of point of care. My question is, how do you ensure quality and how do you ensure proper documentation of a procedure that's done or a visual situation that the doctor interprets on the spot? So how do you make sure that the quality is met and yet the documentation supports that procedure?
So the question is around quality and documentation of quality. So as in anything in medicine, it should be properly, the user should be properly trained. There's lots of good guidelines on what the training is. And there should be some level of documentation. And that documentation, remember, this is a focus exam. This could be part of the medical record. I mean, be part of the record in electronic health record or elsewhere. Sometimes, depending on the scenario, a simple small report will be done. They should be ideally also be part of a QA program, no different than would occur with other things, whether it's EKGs or other things that are done within the hospital. These are pretty simple setups. They're not that complicated, but absolutely that drives improving the quality and making sure we're doing the right things.
Thank you for that. Graduates, community health, humility. I'd like to ask you about the use of point-of-care ultrasound in the remote rural kind of setting, being used for diagnostic purposes by individuals who may receive a different range of pathologies and undifferentiated conditions, and with the high probability of something serious, and obviously we have different case mix. Can you talk to the evidence about how that actually makes a difference and the system aspect that we need to have set up to support individuals in that situation? So I think that's very relevant to this problem.
So absolutely. So the question is around rural integration, primary care ultrasound, and evidence on that. So I'll tell you, there's increasing evidence of primary care usage of point-of-care ultrasound. Now, as I showed you, you could scan a lot of different conditions, but you have to look at what are the conditions that might make sense. If you have a high-risk patient group for aortic aneurysms, yeah, screening of aortic aneurysms might make sense and would be able to then be overread and they could be referred. That's a good example of a condition that's lethal and correctable. Very few conditions in medicine are both lethal and correctable. And so you'd have to look at the exact sorts of conditions like this that would make sense to be integrated. And then I'll also tell you, we're still in the discovery phase here. I've shown you specialty by specialty. Depending on the environment, I could tell you that physicians are diagnosing tuberculosis and cerebral malaria with point-of-care ultrasound in sub-Saharan Africa. That's their environment, though. That's their patient population. But in other rural populations, there may be a disease prevalence that makes sense to use point-of-care ultrasound. Some of this is still being discovered. It actually, I think Newfoundland is actually in a very unique, poised position to discover that, to implement that potentially in a province-wide network. You have a single medical school, very tighter control. That I'd love to see some great research around that. What are the care pathways that make sense for rural health? How do you implement a technology like this? How is remote reading involved or not? Ultimately, how are outcomes improved?
Hi, Dr. McClintock. My name is Christine. I'm one of the surgery directors. we use EFAS a lot in focus for vascular access. And one of the things I'm sort of wondering is, in terms of storage of images of exams for further review by radiology. So as an example, we get a lot of conflicts, say, for a person with cholecystitis. We'll always get a formal ultrasound because it's not going to take the GOR without that. If those images were captured, it would be maybe sort of speed overload going forward. Any thoughts on that?
No, so the question is around storage of images in the workflow. In this case, surgical patient potential cholecystitis. Absolutely, they should be stored somewhere. The options today are PACS, right? They can go direct to PACS. A lot of point of care ultrasound have not gone there for a number of reasons. Alternative, they can be the sort of middleware, and they can be stored there. Either way, the clinicians should have access wherever they are. And if you can work out a system where, if indeed the original acquisition of images is adequate, why would you repeat the test? There's probably another patient waiting for that sonographer, right? If the radiologist who's reviewing that scan says, hey, I'm very confident in this scan, this is cholecystitis, you've just saved the system money. And you've improved the care of yet another patient that's waiting for that slot. So I think these are the ways you have to look at it, how you help the system, but for sure. And there's systems out there. In fact, SonoSite will have a system coming out on October 1 that is going to be designed specifically to answer what you're talking about.
Hi, my name is Leon. I really enjoyed your talk. I just had a question about organizations like C-Focus, that they offer really wonderful training, which is very in-depth, but at the same time, they kind of want people who are practicing ultrasound to have a certain designation. To me, that sort of works against what point-of-care ultrasound is, and that it's very easy, very accessible. So I wonder if that almost shuts people out from using that technology.
So I'm not familiar with this organization, but it sounds like it's a merit badge of some form or some certification. Yeah. So I personally am not in favor of merit badges. I believe the ultimate litmus test is your board certification, your specialty qualification. And within that specialty, you should be qualified to do a range of different things. Otherwise, you could have literally an alphabet behind you, right? I mean, there's lots of these, but sometimes they do play a role depending on your environment. Sometimes they're important for political reasons where you are to get some sort of certificate. There are the RDFS is one. I chose not to take it because it wasn't required for me. It was sort of redundant for me to do that. And there's examples of that, like whether it's ACLS or ATLS or things like this, whether if you're already qualified in that specialty, do you still need that? But so the more important thing to me is, did you get trained? Are you using it? How many cases did you do? What's your competency? So sorting that out, and here at Memorial, that you're now going to be part of an environment that is committed to this. You hopefully will get all of that, right? So I ensure, like example, in the residency training program at USC, we track every one of our residents. They get a certificate at the end of the residency, actually explicitly stating how many point-of-care ultrasound exams they've done and by examination. And that's the real evidence there.
Hi, my name is Carolyn Cash, and I'm the PI Conversion Department here. So I was wondering if one, talk about the pediatric applications, and two, assessing competency, not at residency level, but at staff position level. Basically, how do you determine someone's competent into a pediatric malignancy for the normal?
Okay, so the question is around pediatric ultrasound in emergency medicine at the attending staff level. First thing, just about pediatric ultrasound, it's starting to take off like wildfire, which is phenomenal. There's now recent guidelines, which I'm sure you're aware of. So there's a lot of role and what's unique about kids is they're really easy to scan, very little body fat. I mean, you can see right through a small child. with transducer. It's like a CT scanner. And we now have evidence that shows that, yeah, you can see pneumonia very well, very accurately with point-of-care ultrasound. So in my mind, should pediatric residents be trained in point-of-care ultrasound? You better believe it. I mean, this is going to help them. That whether they're in their office practice or they're working at a place here like here at the Janeway, or they're doing working in some remote location. Now the question about attending competency training and competency. So we're in a mixed environment, right? We will have scenarios where, again, younger students and residents will get this, right? Part of prescribed education, observation, they'll be meticulously tracked, and as we do in other things, right? The attendings are in a different category. Right? They're already qualified, they're supervising. They will need to be handled differently. I will tell you, you will need to separate your attendings. You will need to do a separate course with them, not a mixed course with the residents and fellows. For obvious reasons, and they will need to have sufficient cases. They will need to have enough cases with whatever requisite gold standard or overread. It's a process. In some ways, it might take a little longer, depending on their availability of the attendings, versus the residents are typically always available, always there at the hospital. But that does need to be sorted out. What I do know, and I know you have them here at Memorial, you have qualified faculty now, people that can serve as those leaders to the other. What you need is a nucleus, I would say, in each, not only Memorial as an aggregate, but within the specialties, right? You need a nucleus, and those faculty will serve as the key faculty until you finally get, hopefully, all the attending covers, all the attending staff trained. That's ultimate goal. But even if you were to say, hey, our goal is to have 24/7 coverage of attending that's been trained, right? Get to a spot like that. Any other questions? Yes, in front.
More of a statement. That's one of the big challenges that we face right now. I guess we've been doing ultrasound for years in emergency medicine. We're now starting to take off across the board. It's good to hear that we're going to be training more undergrad students too. Big challenge that we focus is there are a few of us that have been more into it and got to training and formal C-focused training, where you have to do 50 scans on each thing, make sure that you determine, take a piece of paper. But a lot of our faculty won't have that, so discussion around how to get not older faculty, I suppose, but kind of older faculty who don't have C-focus certification, but can still definitely do the ultrasound, because a small group can't do all the work, but an expanded group of faculty certainly can, and that will help deal with the big numbers of undergraduate students, postgrad students who are coming through with the training course, who need to get signed off, I guess, to make sure that they're competent. So we offer the yearly PGY interdisciplinary course for the incoming residents. We train some undergrads as well. We do clinical skills. We train on some lines. But obviously, a small group of people can't sign off everybody. That's what we need to kind of figure out how best to get more faculty involved so we can get the job done.
No, absolutely. And so one of the things that I hear a lot as I talk to physicians is, this protected time and trying to get this. I mean, there's a lot of training that will be required. I loved hearing that you're doing interdisciplinary workshops. There's a lot of overlap between some of the specialties and some of the applications. If that could be combined more, looking for more synergies like that, that might alleviate some of that burden till you get more faculty that are trained.
Well, I just want to thank you very much, Dr. Mandalia, for that excellent comprehensive overview of the evidence base for ultrasound. And And it's also terrific to talk about, especially during the question and answer, about education across the continuum with undergrad, postgrad, and continuing professional development, as well as interdisciplinary. And I think the opportunities for research here, as you commented on in response to Dr. Wilson's question, is exciting. So on behalf of everyone here, thanks very much for the talk.
Great, thank you very much.